Good evening. I'll be talking today about our experience with managing pregnant patients with COVID-19, the challenges we faced, and the things that we learned as we went through this pandemic, both the waves. Um, Trying to cover the entire topic of management of COVID-19 in pregnancy in a span of 15 minutes is like trying to put a camel through the eye of the needle. I'll try to keep it as concise as possible and focus more on our experience and what we learned from the whole pandemic. One of the main issues which we faced during the whole pandemic was the reliability and validity of data. There were so many publications which were coming out. Initially, we didn't know anything about the whole disease. What can be used in COVID-19? And then there was a whole barrage of information which we really didn't know how accurate was it, how reliable was it, how valid was it. But as the pandemic progressed, we had a little better idea, and hopefully, as the days go by, we are much clearer about how things go. There were a few questions that plagued us during this whole pandemic. One was what were the effects of COVID-19 on pregnancy? How did the illness affect a pregnant woman? Second was how did pregnancy affect COVID-19? Where the patients who are pregnant with COVID-19 behave differently than patients who were non-pregnant? Then the next question that bothered us was how do we treat patients who are pregnant and have COVID-19? And finally, the whole question about vaccination in women with COVID-19 and vaccination for pregnant patients for COVID-19. So the first few things were, one was the effects of COVID-19 on pregnancy and the effects of pregnancy on COVID-19. During the second wave, we decided to look back and see how they behaved in the first wave. So in the first wave, we had total in the 913 tests that were done on pregnant women, 70 of them were positive with a test positive rate of 7.67, and this progressively increased during the pandemic. Most of our patients were in the third trimester. This was probably because they were the ones who were getting tested during that time. And the most common syndrome they presented was asymptomatic. So this was the initial days of the pandemic. We were testing all pregnant patients for COVID-19. This could have been the reason why most of them were asymptomatic, followed by influenza-like illness, and very few of them had actual severe acute respiratory illness. And surprisingly, the mode of the delivery, most common was not normal vaginal delivery, but LSCS. This was probably because most of the tests, all the pre-op patients were tested routinely, whereas the patients who were undergoing normal vaginal delivery were not routinely tested. So this might be skewed data because of that, but we need to look at it better. And looking at the outcomes, most of the patients who had COVID-19 during pregnancy, during the first wave, did actually quite well. And only 2 patients required oxygen, one of them required NIV, and there were 3 ICU admissions in total. And most of them did well. There was no maternal mortality during the first wave. And we try to look at the factors which were associated with prolonged hospital stay, that is hospital stay more than 10 days. And patients who had fever, patients who were symptomatic, as expected, had a higher hospital stay. Steroid use was also associated with higher hospital stay. This could be because the patients who were sicker got steroids. LSCS and low birth weight were more in patients who were staying in hospital for less than 10 days rather than more than 10 days. And hypertension was a factor independently associated with increased hospital stay for more than 10 days with an odds ratio of 3. This was what we had expected. So the first wave, the things that we learned where one was, as the pandemic progressed, the test positivity rate, the case rates, they exponentially increased. And most of the patients were in the third trimester, but yeah, this could be because they were the ones who were getting tested. And most patients seem to do very well, and most of the steroid use and anticoagulation use are quite low, as most of the patients were asymptomatic. And there was a high incidence of operative delivery, and which, as I explained, could be because of the routine preoperative screening. But this operative delivery was not associated with increased hospital stay, and there was a higher association of low birth weight and neonatal death. Hypertension seemed to be an independent association. ACE inhibitors are actually contraindicated in pregnancy, so it doesn't seem like it's because of ACE inhibitors. Hypertension seems to be an independent association with prolonged hospital stay. There were other things which we were worried about, such as progesterone use and infertility treatment, but they did not seem to be associated with worse outcomes. The second wave was a completely different ball game by itself. The numbers were much higher. In the first wave we had only 70 patients. In the second wave we had 556 patients. The patients were much sicker during the second wave. First wave we did not have any mortality. The second wave we had 5 patients who unfortunately passed away because of COVID-19. And the whole paradigm seemed to be shifted. It seemed like a completely new disease where the patients were much sicker, required a lot more intervention, a lot more ICU admissions. We are looking at the data, but I'd like to go through our thought process as we tried to manage patients during the second wave with COVID-19. And the things which we were worried about were questions I'll go through the various treatment options and see describe what our thought process was as we went through those. So the treatment options that we considered during the second wave for COVID-19, one was remdesivir. The two main questions that were on the back of my minds were, one was, is it really useful in COVID-19 and in a pregnant patient? And second was, is it harmful for the fetus? The usefulness, initially there were a lot of data showing it seemed to be beneficial, but now when we look back, it doesn't seem to have much benefit with respect to mortality, and does not seem to prevent progression to oxygenation, NIV, or mechanical ventilation. But it does seem to reduce the time to clinical improvement. But in the beginning of the pandemic, there were a few studies which showed it to be beneficial, and based on that, remdesivir was a treatment option which we were using in pregnant patients. Regarding studies on remdesivir in pregnant patients, the largest trial is just an observational study of 60 patients, and out of the 60 patients, 33% of them had some sort of adverse events, but most of them did well. There were no maternal or neonatal deaths in these patients, but we don't have a control group to compare them against. And the second largest one is actually just 5 patients. And the most common side effect that remdesivir seems to be associated with is mild transaminitis, but otherwise they seem to be doing well. But the effects on fetus, that is something which we really don't know. What we know for now is that there doesn't seem to be any immediate effects on the fetus. Most of the case reports don't show any immediate effects, but it is a new drug, and the first trimester exposure to remdesivir, whether that is associated with any fetal anomalies, that we'll have to look, wait and watch. Over the next year only we'll probably get the answer to that. There is a trial, there's a group which is looking at this. They are looking at, there's a registry for patients, pregnant patients on remdesivir. They are still enrolling. Once this data comes out, we'll have a better idea regarding the fetal effects of remdesivir. Anticoagulation was a little bit more clearer. Pregnancy is definitely a prothrombotic state. COVID-19 is another prothrombotic state. So it seems like a no-brainer that we should use anticoagulation. But the question here is whether to use a prophylactic anticoagulation or a therapeutic anticoagulation. And second, whether to discharge these patients on anticoagulation. So various guidelines say different things. For us, most patients who required high flow oxygen, who required ICU care, were on NIV, mechanical ventilation, we definitely gave therapeutic anticoagulation. The patients who had mild symptoms or had low flow oxygen, we managed on prophylactic anticoagulation. Anticoagulation or discharge is still a controversial topic. we did send some of our patients who were sick, required ICU care in hospital at anticoagulation on discharge, and we followed them up on OPD basis after a week, and took a clinical decision based on that whether to continue or not. Steroids, the two questions which we had initially during the pandemic was, one, is it beneficial? Second, which steroid to use in pregnancy? So benefit-wise, it seemed quite clear-cut even during the first wave that steroids were beneficial. They had mortality benefit compared to patients who did not receive steroids. But our question was more regarding which steroid is better. So looking back, looking at the meta-analysis of data right now, dexamethasone definitely seems to be better compared to methylprednisolone and hydrocortisone in terms of mortality. Methylprednisolone, the confidence interval actually crosses 1. And with respect to progression to mechanical ventilation, also dexamethasone definitely seems to be better than methylprednisolone and hydrocortisone. In pregnancy, the issues with steroids are whether the steroids are able to cross the placenta or not. So among the steroids, methylprednisolone and prednisolone, they do not cross the placenta, whereas dexamethasone crosses the placenta. In this thing, first and second trimester, we did not want the steroid to cross the placenta, and so we chose to give prednisolone. In third trimester, where we wanted the steroid to cross through the placenta to cause fetal lung maturity, especially during around the delivery time, we preferred dexamethasone. But in patients who are really sick, who were in ICU, we gave dexamethasone irrespective of the trimester. And tocilizumab was the other thing which came up during the second wave. There's as you see this newspaper article, there's a lot of people running behind tocilizumab, and it definitely seems to have benefit. It has mortality and clinical improvement benefits. But in pregnancy, the thing is, in patients who we are considering to give tocilizumab but really, really sick, in severe and critical illness, at that point, our focus is completely on saving the mother's life, and the fetus takes a backstage here. And these are used in patients who are already on steroids, have rapidly worsening oxygen requirements, and have severe inflammation with a CRP of more than 100. In these patients, we anyway gave tocilizumab because the priority of mother's life was much more here. And the next topic, the final thing which I'm going to talk about, is vaccination in pregnancy. So initially during the initial phases, the safety and effectiveness of COVID vaccine in pregnancy was not really known. Most pregnant women were excluded from the COVID vaccine trials. And so we didn't really have enough data about that. In last year, December, RCOG brought about a statement for clearance of the Oxford AstraZeneca vaccine, which is the same as our Covishield. And this, especially in pregnant patients who are working in a healthcare field or with high BMI, with elderly age, with GDM, or any high-risk medical conditions which have a higher risk of COVID-19. In these patients, they had cleared its use, but various agencies had various different viewpoints, but most of them seem to agree on the fact that pregnant patients are a high-risk population and need to be vaccinated. And in July, the government gave clearance for vaccination of COVID patients, and since July onwards, we are able to vaccinate COVID patients. The vaccine hesitancy is still an issue, even for staff working in the hospital. We have issues where they are hesitant to take the COVID vaccine, and I am sure everyone else is also facing the same issue. And this vaccine hesitancy, especially for Covaxin is theoretically a killed virus and is theoretically safe in pregnancy. But last week, there was a comment from one of the WHO spokesperson saying there is not enough data to comment on whether Covaxin can be given in pregnancy. And this caused a lot of anger and concern among patients who had received, pregnant patients who had received Covaxin. But we need to wait and see. the final data. Now we have vaccinated enough patients, and we should have enough data. We'll have to wait and see about the safety of it. But theoretically, both the vaccines are safe in pregnancy, and we should try to encourage as many women as possible to get the COVID vaccines. This is just a brief overview of our experience with managing pregnant patients with COVID-19. It is, we learned, we were confused, and we learned more. So most important thing is to keep ourselves safe and keep our pregnant patients safe. Every pregnant life matters, because we're not dealing with just one life, but two. And it is an important thing to keep reading up, because every day the data keeps changing. There are new things which keep coming up every day. And it is important to keep abreast of the latest information which is available. And you also need to have the common sense to make out which one is the correct information, which one is wrong. Thank you.